This conference will now be recorded.
Hello, everyone. I will start over now that we are recording. And welcome to the October 19th North Country Regional Emergency Medical Advisory Committee meeting. Again, this is only our second virtual meeting. I will be sharing my screen with documents, and Jonathan will be monitoring the chat room. So if you have something to say and haven't been able to get in, just put S or a chat or something in the box for Jonathan and he will let us know. Please make sure that you're on mute so that we don't have a lot of background noise as we move through this. Being as though the physicians are the only ones who vote, I think I'm going to, with the REMAC meeting, move forward with votes as we come upon them because they shouldn't take too long. And we will kick this off with the pledge. I ask that you please lip sync as I stand, and respect the flag and say the pledge, only because too many voices do not translate. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Thank you. Now we'll move forward with the agenda. So we did send out the June 2020 minutes for approval. And because they are a transcript and they're long and sometimes difficult to read, we did move any of the motions for the top to the top of the document. So I would entertain a motion for approval of the June 2020 minutes. Anybody out there make a motion?
I'll make a motion. It's
Okay.
Ryan.
So Brian Coates has made a motion to approve the June 2020 minutes. Do I have a second?
I'll second. It's Paul Barter.
Okay, Paul Barter seconds. Any additions, deletions, corrections? Okay, I'll take silence as being golden. So all in favor, and I will just run through the physicians' names. And I'm not 100% sure who exactly is on yet. So Dr. Cartier?
Yes.
Dr. Coates made the motion. Dr. Delaney?
Agree.
Dr. Heiss? Dr. Heiss on?
She is.
And Dr. Howland's excused, correct?
Yeah. There you go. Rose is here. I just couldn't get the damn mute. Sorry.
Is that a yes?
Yes, Heiss is here.
All right. Dr. Gray? Is Maya on, Jonathan?
She was. She's been emailing me.
Okay. Dr. McKinnon on?
No.
Dr. Maynard?
Approve.
Dr. Purcell on?
Nope.
Okay, Dr. Snicer? Dr. Snicer? I know he was on. Okay, well, we have the majority of them approving it, so.
I did just get an email from Maya. She's having trouble with sound, but she approves.
Okay. And we lost Dr. Snicer. Okay, he may have some connection difficulties. All right. Moving on to the DOH enforcement list. Debbie, do you want to read those off?
I certainly can. The state's been very busy. First one is dated July 22nd. Revoked effective July 6, assessed a civil penalty of $2,000 for violation of 10 NYCRR Part 800.16A 7, 13, and 14, Thomas Dean from Saratoga Springs, New York. July 28th, for violations of 10 NYCRR Part 800.15B1 and 800.16A 9 and 11, Francis Feely from Cohocton, New York. July 28th, voluntary surrender effective 7/7 for violations of 10 NYCRR Part 800.15B1 and 800.16A2 and 3, Christina Crescencio of Bethpage, New York. August 4th, revoked effective 7/13 for violation of 10 NYCRR Part 800.16A and 2, Letitia Wright from Staten Island, New York. September 22nd, suspended for 6 months, effective 9/14, assessed a civil penalty of $2,000. The civil penalty is suspended and ultimately forgiven with no further violations for 3 years, beginning 9/14 of 20. For violations of 10 NYCRR Part 800.16A 13, Eva Santiago from Baldwinsville, New York. September 22nd, suspended for 1 year, effective 9/14/20. The suspension is stayed. Placed on probation for 2 years, effective 9/14/20. Assessed a civil penalty of $2,000. For violations of Public Health Law Article 30, 3006-1, 3053, 3012B, 3012D, 3012F, and 10 NYCRR Part 800.21 JKL 800.21P 1, 3, 4, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 800.23A, 800.24D10, 800.24F14, and 800.26. Bedford Stuyvesant Volunteer Ambulance Corps in Brooklyn, New York. September 29th, suspended for 1 year, effective 9/23/20. The suspension is stayed pending completion of a full PALS and ACLS course within 6 months. Placed on 3 years probation, effective 9/23/20. Assessed a civil penalty of $5,000. For violations of 10 NYCRR Part 800.15A2 and 800.3 AM, Nicholas Walker from Plattsburgh, New York. October 6th, suspended for 1 year, effective 9/23/20. The suspension is stayed. Placed on probation for 2 years, effective 9/23/20. Assessed a civil penalty of $2,000. Must hire a consultant, provide regular reports to the department. For violations of Public Health Law 3006-1A and 10 NYCRR Part 800.21A, 800.21P 6, 7, 11, 12, 13, and 800.23A. Bensonhurst Volunteer Ambulance Service in Brooklyn, New York. The last one, dated October 9th, issued a formal reprimand, placed on 3 years probation, effective 10/6/20, assessed a civil penalty of $2,000 for violation of 10 NYCRR Part 800.15B, Diane Wagerish, Wagerik, from Old Bridge, New Jersey. That is all of them.
All right, wow, that was quite a list. Any discussion on the DOH enforcements?
Debbie, if you have a PDF or something of that list, would you mind sending it to me? I can attach it to the transcript.
I can certainly do that, no problem.
Thank you.
All right, moving on to correspondence. The first correspondence we had, and it was right after our last meeting, but was the announcement of Westchester as a stroke center. We have been receiving renewal certificates for the services, which is actually very nice. We never used to get a copy of them. We'd have to wait for the services to send them. I will have a list of those in my program agency report. I did forward to everybody the air medical stats. Mercy Flight sends me their stats for usually Jefferson and Lewis County, and I combined them all since our last meeting, sent them out, as well as the quarterly report from the clearinghouse from Air Methods. So I'm not sure whether Colleen sent me an email and said she didn't think she was going to be able to make it due to an appointment running longer than she had planned. So I'm not sure if Mark Tuttle is on or not. He may have something further under old business or new business later with Air Medical. We also received an
Mark is
update.
here.
Oh, is Mark here? Mark, do you have anything to add on the Air Medical side?
I'm all set. I don't think I have anything new unless someone has a question.
Okay. Did anybody have any questions on the Air Medical stats that were sent out? The clearinghouse report for LifeNet, or I believe Matt Yalton is on, if there's any questions for Mercy Flight.
I have no questions. Can you hear me now, Ann? It's
No.
Dr. Snizer.
There you are. Yes.
When I went to the screen on the GoToMeeting, it logged off of my phone. That's why it hung up on me.
Oh. Okay. Well, welcome back.
Thank you.
So the other correspondence we just recently received, and it's from SUNY Canton, and I'll just pop it up there on the screen. So again, just a notification that, sorry, after much discussion, that they've decided to drop the EMT course sponsorship. The current class has been completed, so they did hold on to it through up until this month. They're not going to renew. They ended June 30th, but with COVID extensions, all course sponsors were extended till December 30th. And we are all working very closely with them, and I do have that in my report. We can talk a little bit more about that when I go through my report. And then the last question, or the last correspondence, was EMS update from Clifton Fine Hospital that Dr. Delaney asked me to share. We got this a little while ago, but because of the distance between our meetings, I'm actually really glad I remembered it. So Clifton Fine Hospital took a look at some of their pre-hospital issues as far as getting ambulances out to calls during the daytime when a lot of the volunteers are working. And they developed a plan to increase their number of calls that Starlake Ambulance would be able to respond to during the day. And that kind of gives you an idea what they did. They, brainstormed some sessions with community-based stakeholders, and they actually granted permission for their employees who are volunteer firefighters or members of Starlake Ambulance to take reasonable leave to respond to emergencies. They encourage their staff to become volunteers, and they developed a survey tool to be used at a health and wellness fair to help try and recruit for the local EMS agency. So then kind of what their data showed is in, 2015 through 2018, Cranberry Lake was answering a large number of calls. So for the department. Anyways, when all was done and said, and I apologize, just made that smaller there, sorry. When all of that was done and said, they have, let me see if they have increased the number of patients that the ambulance is able to get out. So again, it was just, a shout out to Clifton Fine Hospital for, jumping on board and looking at this and really working to solve the problem as a group. And we all know that EMS is in a crisis, and that it's going to take everybody working together as a community to help ensure that our community folks are getting the care that they need by getting ambulances out to them. So just a great shout out to them. So, and that is it for correspondence. If anybody wants any more information on this, they can reach out to me later or reach out to someone at Clifton Fine. So, does anybody have any other correspondence? All right. So moving on to old business. Mark Devers, would you talk about the state EMS meetings that were held in August following our last REMAC meeting? They are scheduled again to be held December 8th and 9th. The ones originally scheduled for, I can't remember whether it was October or November, were postponed until December. So all yours, Mark.
Good evening. I believe the notes will be attached to the minutes, so I'll hit the highlights here. There's been some Article 78 legal action filed against the council on a CON decision. The Bureau is hiring new staff, including a new EMS for Children program director. Amy Eisenhower was hired I believe in August, and she started in that position kind of with a pretty strong goal of improving pediatric care and pediatric equipment requirements throughout the state. The CMAC report, they suspended the COVID-19 triage protocol as COVID died down. Whether we'll see that reactivated in the next few months is of question. There was some lengthy conversation and then an ultimate approval of terbutaline at 0.25 milligrams IM for bronchial spasm for children above the age of 12, and 0.01 milligrams per kg in 6 to 12, not to exceed 0.25. May be administered by AEMT, CC, and paramedic. And this was in response to kind of minimizing the aerosolization and some concerns with epinephrine. They did some scope clarifications to include pharyngeal swabbing and immunizations to be included in the scope of all levels if trained and equipped. A whole bunch of protocol conversations, and by the sounds of it, with the collaborative meeting earlier this week, there's going to be a handful of protocol revisions coming out at the next meeting in December. On the education side, they are not issuing certification cards to refreshers, only to original students at this time. And I believe they've started issuing certification cards to everybody, but there's quite a backlog. So the verification out of HCS does work. And in many cases, education is education and separate from EMS. In other words, education, basic EMT classes, paramedic classes, AMT classes are done following an academic institution or piggybacking on an academic institution. And so COVID rules do apply to them. So training is becoming a bit of a challenge, especially with, you know, the questions as to opening and closures based off of COVID and COVID numbers. And I believe that's basically the highlights. The only thing I will add is the state's been talking a fair amount about enforcement, especially when it comes to COVID-19 related PPE. Basically, they're saying they're at the direction of the governor's office. For everybody, you either follow the rules or get fined, and they're up to $15,000. And ambulance services are not exempt from that. They have said that you cannot socially distance if two people are in the front of the ambulance, so people need to be wearing masks. And they are expecting masks to be worn on calls, and appropriate levels of PPE based off of patient complaint. And we haven't seen a ton of it yet, but they are being asked to make a presence and appearance and work on enforcement initiatives through that end. And that's all I have, unless there's any questions.
So as far as I know, that no fines have been issued at this point, and that was as of the last call that we had. So, but again, we want to make sure that we're protecting ourselves and our patients. So Mark, while you're there, RSI is next on the list.
So I've got 2 agency applications and 6 provider applications for RSI that meet the requirements for the policy statement. The 2 agencies are Lewis County Search and Rescue and Governor Rescue. And the providers are Josh Levesque, Josh Jenner, and Mark Tuttle, myself, Melissa Brook, and Roger Winters. All meet the requirements. The only thing that's actually lacking is the testing, and that's because there is an annual testing requirement. So any testing that would have been done has expired. So my hope is to get an approval to move forward with that from this body, and then make testing arrangements with probably Dr. Maynard or Dr. Delaney or Dr. Gray in the next few weeks, possibly in Watertown, and try and get everybody there in one group and just be done with it, so we can move forward with this endeavor and move forward with it. So at this point, I am as little heartburn as possible with the applicants and the agencies as far as oversight, qualifications, training, etc.
So do I have a motion on the floor for the approval for testing of the RSI? I don't know that we need a motion for that because it's already in a policy. Actually,
I had a question, Anne. There were, my understanding, there were 2 components, and Mark, if I missed it, I'm sorry. We already have a policy for people who are interested, you know, to get to the testing time. So I agree with you. I don't think we need a motion on that. But isn't there an application that the actual agency needs to fill out to apply to be an RSI agency? Like, so there's 2 parts to this, correct? And I was wondering if you can just touch upon that again.
There's 2 parts to it. There's the agency level, which at this point I've got applications from Lewis County Search and Rescue, and Governor Rescue. And then there's a separate part for each individual provider. So they would have to be part of an approved agency and then an approved provider as well.
So if we have do we need to vote on this, or are you giving more an update that 6 people are ready for testing and you're going to arrange that?
At
So
this point, that's up to this body.
it sounds like you need an approval for the agencies to become RSI.
If I remember, yes, I need approval for agencies to become RSI so we can move, because we can't credential the providers until the agencies are approved.
So were we given that paperwork to review?
It's actually just a paper that says we're interested, with a letter from their medical director. Both agencies have letters that I can pull up if you give me just a second and try and share them.
All right, so my apologies. I didn't realize.
They will be attached to the minutes according to Jonathan.
So would you guys feel more comfortable waiting to see the letters? Or is that something that you want to move forward with tonight?
If the doctors are comfortable, they could maybe read the letter and indicate who their medical director is, but I think they should probably be voted on individually, and maybe the doctors would feel more comfortable doing that later in a Google or something.
I have the letters right here that I will screenshot and send to
Send them to me.
Anne, I guess.
Yeah, I'm doing them. So is there any discussion on those 2 agencies? I actually, the fact that these weren't sent out, it's probably better to give the docs some time, honestly.
If you wouldn't mind, Anne, can we do this via email vote like we've done in the past? And you can attach, just as a reminder, it's been I think a long time since I looked at the RSA protocol that we all agreed to. And then from an agency perspective, what I'd want to know is if they're committed to get the backup airways in place, what kind of education is being done. I believe that's in the protocol, the expected education and how often, correct? All that's spelled out already?
It is all spelled out, and in the policy statement, the requirement for secondary airway is also in there. There's a initial requirement of the difficult airway course, which everybody has completed, and then the annual testing requirement, as well as ACLS, PELS, etc.
So I think probably the best thing to do, and again, the doctors can certainly shoot me down on this if they would like, or Dr. Delaney can shoot me down on this if they would like, is that I put this together. I'll work with Mark, put this together, but now that we're meeting virtually, even if we have to do a meeting in another month, that's certainly possible. Just to give them some time to look at it, think about it, if they have any specific questions or anything. So, and again, I apologize. I didn't realize that. I guess I forgot that you had the agencies to be approved.
I think that's a reasonable plan, Ann, if everyone else is comfortable with that.
That would be great. Thank you.
Mark, are you good with that?
I'm fine with it.
Okay.
I have them right here, so I can send it out to the group right now if you'd like. Then it's
Well,
taken care of.
I was gonna say, just hang on, that way I can pull the policy and everything, so they have everything all in one email. Versus getting everything in separate emails, if that's okay with everybody. Not that we don't get bombarded with emails. So is there any specific questions on RSI other than what's already been discussed? Okay. Hearing none. Is there any, oh, I have other old business here. Other old business, so protocols. So the collaborative group met virtually and discussed the protocol submissions that had come through on the port that's open for all providers and had previously been advertised through the region. And I believe there's a link to it on our website. Correct, Jonathan?
Yep.
So that they can put in any submissions. We did get off key a little bit because of COVID, so there was a large number of them to go through. I did send this spreadsheet out. I'm not going to spend a lot of time on it, but basically what I need is if there is discussion or things that you would like us to add in, or if you're interested in getting on any of these calls, to please let me know. And then there's a couple items which are things that I think we maybe will want to work on within the region. So again, if we have any volunteers to work on any of the stuff that we talk about, please type in the chat box or email me or let me know at some point so we can get you involved in the process. So I'm just going to kind of go through them quickly. I'm not going to read all of them. As I said, I have already sent this out. So again, the first one was using ketamine for pain management. And the provider put in a recommendation, and the collaborative physicians of Fulliger, Daly, and Dr. Cushman were going to look at ways to provide clarification, the language and protocols on how to give, as well as adding some dosing tools to help reduce med errors or protocols to the appendix. I did bring forth that we've seen some significant CQI issues with ketamine, so hopefully we will see some change along that line that will help make it clear for the providers. I apologize.
Is there any way you can make that a little bigger?
Oh, let me see. Yes, I'm sure there is. Okay. All right. If I make it much bigger, I can't hardly see it on my screen. Is that better? Again, everybody should have this. So there was a discussion on IV nitroglycerin being an option in the ambulance for critical patients. Again, this is something that they all support, but no action was taken on this request because currently, right now, Part 800 does not allow glass containers over 249 milliliters on an ambulance. So until Part 800 changes, that will stay the same. But it is something that they are actively pursuing to move forward. So, so the next one, oh, I'm having trouble with the, okay, all right. So the next one, there was a large discussion on intranasal use of Versed. But basically they decided to take, or their stance was kind of a no on this, basically because it's safer to come at them from the side and give them an IM, which is faster acting, than to put your hands near their mouth, near the mouth of a patient who could potentially bite you. So, and just before I go too much farther, one of the comments was there has been some absolutely spectacular suggestions put forth. So even though not all of them were accepted or entertained, they really, most of the providers put good reasoning, included research. So the portal is working very well to ensure that we're hearing what providers are interested in. The next one was to allow labs to be drawn en route to the hospital via vacutainers. It does sound like there may be some regions that allow this, but one of the discussions was a lot of the hospitals don't accept them. So they're going to kind of leave it as a regional procedure option and not put it into the protocols. We currently have a policy statement that we're not drawing labs. And other things that kind of were thrown into this in the discussion is, you know, under vehicle and traffic law, there is potential that agencies could draw labs, but they need to have policies and procedures in place and be trained appropriately and all of that, which is not anything that regionally we can stop, but the standard practice of drawing them routinely on patients is not something that we currently do here in the North Country. So let's see what he put in here. So again, it's not anything that the collaborative protocols are, they're going to put into the protocol. It would be a policy. And Mark, feel free to jump in if I don't elaborate on the, you know, what they talked about on the call. Mark was on the call as well. So there was some discussion about some of the language surrounding CPR and defibrillation and how it should be wording, whether they should transport or not. But basically they sorry, I apologize, my screen keeps jumping. They decided not to pursue this. Evidence does not support routine transport of cardiac arrest patients regardless of transport distance. So it'll be left to the provider discretion based on regional practice. And again, any of the discussions in here, any of the suggestions that surrounded any CPR or AED were kind of put that they will be looked at again when AHA issues the new standards here soon. That should be released the end of October. So the next one, sorry, was basically just talking about links within the application. And most of those will be, they're formatting and going back and forth. So this one specifically was, if they update something, make a correction, the app automatically updates. And instead of notifying the, you know, the provider may not catch what updated. So they're going to look at some options on that, but that's more of an app formatting issue. The next one was talking about adding ipratropium bromide to albuterol for BLS. And really the discussion that came down on that is, I guess what they referred to as scope creep. It's not within the scope of practice for the EMT. And they also thought that itself, the ipratropium itself does not affect outcomes, and adding it for a significant outcome benefit is expansion of scope costs, so they weren't going to pursue that. Oops, sorry. My screen is so big, I have it so large so you guys can see it. I have a hard time going to the next one. There was some discussion over the wording within environmental cold emergencies that, instead of saying maintain a warm environment, this provider wanted to see an ambient temperature range. I think the discussion surrounded that basically they don't want to set a provider up for failure, and we're not necessarily monitoring the temperature inside of the ambulance. We're just making it as warm as we possibly can, so they aren't going to pursue adding any references there. Basically, get them into a warmer environment than that they were at. So, musculoskeletal trauma. Again, this is just asking for a link to go to another protocol. So that's something that will be done through the app. Let me just double check and make sure that wasn't. Yeah, it's a software app issue. Suspected spinal injuries. Again, there was some discussion on destination for these patients. And again, this kind of looked at enhancement of the links that will take them to the other protocols. So it turned out to be a software app issue. Sorry. Vascular access. I got to remember. I think, again, this is just a clarification and a software app issue. Just making sure that they are consistent with each other and with their titles. So that's what that one was. So under altered mental status, they talked about, I'm never ever going to be able to say that correctly, but it's a form of glucagon powder that's administered nasally. Again, at the CFR and the EMT level, this is outside the scope. And again, the cost for the medication, they decided not to pursue it until the cost comes down. And even, I think they did kind of search it out, but still a dose of that, I think the new kind they found was like around $250. So, but it is also out of the scope of practice for that level of care. So there'd be more involved in that. There'd have to be a pilot or a study, etc. Head trauma. So there was discussion on hyperventilation rates. And again, all the discussion surrounding this request was it's more educational. I think that it may have resulted from the CMAC policy statement going away. And again, they talked about the 3 H's. You want to make sure that your TBI does not become hypoxic, but it's not indicated to hyperventilate them either. So again, there's a lot of discussion surrounding that, and that's more educational in nature. So there's a possibility for an educational session that may be very beneficial within the region, although I don't think this came from our region. But again, it's still a good education session for folks. So then there was a large discussion on epistaxis. and about the application of nasal balloon catheters. And then there did follow, well, they weren't, I don't believe they were necessarily in favor of an application of a nasal balloon catheter for an epistaxis in the field. There was some discussion about having an epistaxis protocol, and also discuss consideration of TXA within that protocol and others. And Dr. Bombard from Mountain Lakes actually created a protocol that was sent out with this list that I'm sending you. So if you have any comments, etc. on that, if you would please share them with me so I can kind of understand how you guys are feeling about that. The use of terbutaline, again, that was approved to go into the New York State formulary, especially in light of COVID. So that is absolutely something that we could add in if needed, especially during times of a pandemic. And we just have to follow the procedure. So that was kind of left at that. So then there was some other discussion on the epistaxis protocol, and again, that was sent to you. There was one area that indicated that they were using Afrin in the field, but as far as I know, that's not in the formulary, and I don't know of any of our ambulances that have that on there, so I'm not sure where that came from. So I do believe the discussion of famotidine, I'm never going to say it right, famotidine. Apologize if I did not pronounce that correctly. But again, there was discussion surrounding no inclusion of H2 blockers in consensus guidelines for management of anaphylaxis, and has limited effect on GI bleeding. So the cost kind of outweighs the clinical benefit, and they're not going to pursue that at a time. But again, as you can see, that the folks putting in these recommendations, as you can see, they put in, the studies, where they got the information from. So it's really great that the providers are looking at that and they're doing some research. The refusal of medical attention, there was some thoughts that it really needed to be looked at by somebody legal, and they are going to have that reviewed by somebody legal to see if there is better wording that could be in there to ensure that everybody's protected. Blood product administration, well, they absolutely agree with the administration of blood products pre-hospitally. There's a lot that has to be done through the Wadsworth Lab, the Blood and Tissue Council, and a whole bunch of other stuff before that can happen. So that's kind of where that was left. And I don't know if that's later on here. Let me look at something. Okay. So this one, best practice with ETCO2 monitoring. They didn't put a lot of prescriptive language. This is talking kind of about the agitated behavior protocol. But they will adjust the protocols just to add some supportive but not restrictive language about using ETCO2. I mean, if it's a safety issue and you can't use it, again, if they're sedated, they should be able to, but that was some discussion on that. So It was just a question on the required if they weren't able to do so, but once they're sedated, hopefully that they can do that. So TXA, there was a lot of discussion on that, and everybody seemed to be in favor of moving towards TXA use in the field. And it was suggested that the group work with the State Trauma Advisory Committee to develop protocol revision or inclusion for TXA in the field. And then the last but not least was some wording change in the cardiac arrest protocol, and they're going to wait till the new standards come out. And I think I may have missed one in there somewhere. There's also some discussion on extraglottic airways at the EMT level. I must have skipped that one somewhere. But again, that might be worthwhile to explore doing, especially in this area where you may not get ALS, to explore putting together a demonstration project. There was one such that was done, and somebody is going to pull out the information that they had on that. And if they are going to kind of get that going again, I think that that would be maybe a good study that the North Country would kind of think about jumping in on. And the other one, and I don't know how I skipped it going through the list, I must have skipped some of them, I apologize, is inhaled isopropyl alcohol for nausea and vomiting. So there's some literature out there. It's promising, but it's not conclusive. Again, there's a worry about scope of practice as this was presented for all levels of care. There was discussion that, well, you know, is this something that a patient can self-administer as an option? But they don't want it to overshadow the efficacy of giving Zofran, as Zofran is tried and true for nausea and vomiting, which then led on to further discussions about Zofran for the EMT, but that's definitely a scope creep issue. And, but there's also an opportunity for a quality improvement study. And you know, especially in the St. Lawrence County area, we're seeing where not always, you can't always get ALS to give Zofran. So that was the other one that Mark and I thought that maybe something we could work on, possibly coming up with a plan for. I think I got most of them. So thank you all for being patient while I talk. So my first question is, would you guys be interested, is the inhaled isopropyl alcohol anything that you, what are you guys' thoughts on it? Any?
Hey, it's Andy Cartier. I really don't see any reason that it should not be available. It seems like an incredibly low risk for potential benefit, especially like you're saying, areas that don't have ALS coverage. So I see no reason to not allow that for all levels.
Anybody else?
Yeah, it's Ryan. I agree with that. So the initial study on that compared Zofran to like just an isopropyl swab that the patient held in their hand and took several deep breaths with it. And you know, it's a subjective measure, so you can't really prove its effectiveness. But it was shown to be non-inferior to Zofran, and there's really not much downside to it as long as they're not like eating the alcohol pads. So it seems like a reasonable thing to consider. It's pretty easy to do.
It makes me giggle because somebody will probably eat the alcohol pad. Maya or Sarah?
Yeah, I'm in support.
I'm in support as well.
Dr. Sneisser?
I'm in support.
Okay. And I'll take a yes from Matt unless he chimes in, so he doesn't have to unmute with his kids.
Yeah, they're eating dinner now, so they're quiet, but I'm on board.
So I will work on, so this, again, as simple as it may seem, I'm gonna have to work on putting together a proposal and getting it approved and doing it as a project. So that's gonna take some time, but I just kind of wanted to have the support of the REMAC before I started diving into any, type of project like that, so,
Hey, Ann, it's Andy Cartier.
yes.
Who is working on the TXA stuff? I'd be happy to help out with that. Our TCCC guidelines just got updated in the past month that we're doing just a 2-gram slam of TXA now. And I'd be happy to help out whoever is working on that with the stack to provide additional resources from the military side if necessary or if helpful.
Okay, I will hook you up with them, and let me just see if he put names here. I'm gonna guess that Dr. Daly and Dr. Fulliger may be up to the stack. Yeah, let me do an email introduction. And I know previously in another meeting at one point, I believe it was Westchester was going to do a demo project using TXA. And we had agreed as a REMAC to get on board with that.
Yeah, I remember that.
That never came to fruition. So I think as a whole, unless something has changed, that my understanding was that the REMAC approved that. So I will do an email introduction.
Yep, that's fine. I'd be happy to help out with that. I can get them our guidelines and references and stuff too.
Okay. So what I will do is to Dr. Cushman, Fulliger, and oh my goodness, Daly. They're kind of the ones that are working on most of that. Usually, I don't know which one of them will be going to the stack, but we can discuss that. So, all right. Dr. Heiss, are you good? I think I didn't grab you with the alcohol one there.
That's all right. I like the idea of the alcohol. So I'm in agreement. Thank you.
So everybody heard that, right? She likes the idea of the alcohol.
Couldn't resist saying it that way, eh?
Thank you. All right. I think I got most of them. Mark Devers, did you have anything else to add to that?
I think you hit them all pretty good. The one thing that I did hear, they were very ambitious about TXA was kind of the impression I got, especially in rural settings as a regional option. Other than that, I don't have much to add.
Okay. All right, so if anybody has any concerns about anything that, we've talked about, send me an email if you have a chance to review that epistaxis protocol that was sent out. And you have any suggestions, comments, additions, deletions, whatever, please email that to me so we can provide that feedback to the group. All right. So while I pull up the BLS 12 lead, Debbie, do you have, because of course I didn't put that in the folder. Do you have anything on the difficult airway? I know that as of last I knew, we hadn't because of COVID, hadn't been able to get a hold of, or hadn't had an opportunity to get a hold of anybody to see about doing a virtual sign off.
I did send a couple emails to Rudy about doing that. I did get a response that said that they were not in the office, that they were working from home with limited access. So I did reach out to his cell phone and ask him to call me. I have not heard from him, but I will follow up with him again so that we can try to get that taken care of, as we want to get that done in this budget period, and everything else is going virtual, so maybe they're just working on putting it together, and maybe we can pilot it for them to see how it goes.
Okay. So, any questions on difficult airway? All right, so the BLS 12 lead project that was approved to move forward at the last meeting. So I sent out all the documents for approval. They did find one typo in the test, which I have since fixed. But other than that, we actually had some BLS, or had a BLS agency representative kind of review it. And some of the changes when I did this are referencing what needs to be, what's required from the state policy statement. And what I did is, with some of the other adjuncts, we have a separate form for everything, and forms get lost in the shuffle. So kind of as an ease for us in trying to have everything in one place, we went through and, just did the demographics of the agency. And here is the requirements, and these requirements are from the policy statement that DOH has put out. They're going to have to do a new 4362 medical director verification form, as well as policies that include all of those items, which I put together in some generic policies, so they wouldn't have to recreate the wheel totally, and they'd have a guidance that they could edit to meet their agency processes. So then highlighted here on this form, can you guys see that okay? Jonathan, are they good?
It's good.
So there was discussion about the education. We thought it should be a CIC, and that documentation of this training will be submitted to the regional. That should be region. To the region at least yearly. So the discussion point is, do we add this on the BLS skills sheet set that we have? Or do we just put this into our system and make them attest to this and keep the rosters at their agency? Again, even the BLS skills forms that they're doing are kept at the agency, and they attest to this in the into the system. I don't foresee a large number of agencies getting on board with this due to cost of equipment. So unless it's already an AMT agency or ALS agency that has the capability, I don't think you'll see too many BLS squads going out to buy something just to do 12 leads. So any thoughts on that? So first, is it okay? Does everybody agree that a CIC should do the training?
Yeah, that sounds reasonable, Ann.
All right, so any
And
thoughts?
I would like to see it be part of the CME form, because, as we're trying to get more toward doing scenario based, it can be part of the scenario for the basic EMT when they do their skills yearly, and the advanced providers, to just tie it all together.
All right, any other thoughts on that? All right, I will add it to, so I should fix my capitalization there too. I will add it to the BLS CME form, which really kind of almost makes sense. I hate to make that longer because it's many pages already, but that's where the rest of them are. So another formatting, moved off a little bit on this, but the next page is the BLS Medical Director Agreement for 12 lead, which is required by the policy statement, again, to ensure they understand what their role is in BLS 12 lead acquisition, along with their demographics. So unlike many of the other adjuncts, the receiving hospitals need to be involved in this, and will have to sign off that they have, worked with them and that they have a process in place. And then again, the agency chief operating officer will have to sign off on this. So the next one I put out is just another page with that, because this will be only if needed. So, for example, I use the BLS agency or the AMT agency that I run with. We could transport to Claxton Hepburn, or we could transport to Canton Potsdam Hospital. So we'd have to have an agreement with both agents, with both hospitals, and understand the transmission process and educate both hospitals on, what they could potentially see. So that's just another page. If there's more than one hospital, they would need to complete that page. Any additions, corrections, deletions, changes on this form?
And does that mean that we need to get the Syracuse hospitals to sign off on it as well?
Well, that's a good, we probably, well, so they already have a process in place. I didn't think about that when I did this, so I guess that would be up to this group. I think it's just more for the local hospitals. Because usually if you're going to a Syracuse hospital, you've linked up with ALS, maybe, maybe not. Would that be the case, Debbie, if you're heading that way?
That should, unless bar something where there's no ALS available, that certainly should be. And knock on wood, we haven't had an instance where we couldn't hook up with somebody, NOCA, MENA, working our way down through. We, knock on wood, haven't had an instance where we couldn't get an ALS intercept.
Yeah, I think this is more for our local hospitals that are new to, and the biggest thing with the BLS providers getting the ECG is it's, in your case, they may make a decision to send you directly there. In cases such as, if it's Canton Potsdam Hospital or even Claxton Hepburn, there's not a cath lab within a good time frame. I don't foresee them diverting them necessarily to another hospital, but I think it may be a huge benefit to them to see that ECG early before the patient comes in. And Dr. Coates, you can throw anything in there since you're from one of the hospitals I mentioned, unless we lost him. So I think that's an interesting concept of this BLS 12 lead acquisition. I think it's going to mean different things to different hospitals. For example, Samaritan, it may mean moving them towards Syracuse, right directly to the cath lab, where for other hospitals, it may mean getting thrombolytics ready early and potentially arranging for transport out earlier.
Hey, it's Ryan. Sorry, I was having trouble with my mic.
Yeah, there you go.
So I think the biggest thing for us in our little region, one of my biggest problems is when I get calls from BLS for calling a pre-hospital code. Often we get in the report, no shock was advised, but they don't give an interpretation of the rhythm like at all. So I don't know if the AEDs say no shock advised because it's sinus rhythm and they're just hypotensive, they're not perceiving a pulse. So it's always a very uncomfortable med command call to let them call a code on scene when it's BLS only, because I feel like the history is not as complete. So potentially if they were doing BLS 12 leads and they could send it to us, if you see like asystole, then I mean, clearly it seems more reasonable to call the code. But I don't know that it would help us kind of expedite ACS as much, I guess, other than we could clear a bed and kind of get the wheels in motion. But I'd be interested to see, I guess, how that plays out.
And again, like I said, I think this will, I don't know that you'll see a lot of agencies jump on to this, but you may see, your Potsdams, your Cantons, Ogdensburg, Messina that already have, Tri-Town. Let's say especially for Tri-Town, that's, a good 30 to 45 minutes away from the hospital. So it'll be interesting to kind of watch this and do some QA/QI on it and follow up with the hospitals to see if it is a benefit, if we do get agencies coming on board or not. And again, one of the goals of the whole program is that they're efficient enough that they are not delaying care. I mean, that's a huge, huge point in the education. So there's a lot of forms to go through. So the policy and procedure, I'm going to ask that if you guys will look through that and let me know if anything needs to change there. But I think that the main things we need to approve are going to be the education, which was sent out to you. So I'm not going to go through that today. Hopefully everybody's had time to review it, but I just kind of wanted to look at the 12 lead acquisition and transmission report, kind of the CQI. And again, it started off as the STEMI CQI form, but then thinking about it not always being used to divert somebody, hopefully we can get those answers to the questions of what we just discussed through the 12 lead acquisition and transmission report. With many agencies being on electronic platform, I'm better able to figure out who did 12 leads and who didn't, unlike back when we relied on the paper forms that we can follow up with agencies. But basically there's a section for EMS to fill out, who is the hospital, again, the question is in here, was medical control order received to go straight to a cath lab, which is not going to be applicable in many areas, but if they do, what was the destination hospital? And some times in there. We're going to ask the emergency department, we're going to ask EMS to leave this form at the emergency department, and they should complete this part of it. And then, especially so we can look and see if they received thrombolytics, did they end up going to a cath lab eventually? And then from there, if the ER can send them back to our office, then I can follow up with the cath labs, depending on where the patient went, to see if we can get some better data than we've had before. So it'll be interesting to see what data we can pull out of this if it's used. So, and then one of the suggestions that somebody else had given me was to just kind of add a checklist at the bottom, which will hopefully help our BLS providers ensure this is kind of what these are the things we'll be looking at when we look at the PCR. So whoever has the CQI form, they go to do their documentation, they can make sure that their signs and symptoms, reflected the need for a 12 lead, that they attach the 12 lead to their PCR, and that their med control call was, documented appropriately, right? Because they won't be reading the ECG, they're just going to be sending it. And they should be, calling the hospital and saying, hey, I just sent you a 12 lead. So just making sure stuff is appropriately documented. So is there any questions or concerns on that?
And just the one thing that we found is once they fill out the first top part, for them to remember to make a copy to put with their packet so that their agency director can follow up to make sure that it does get completed. And if it's been lost or whatever, all the information you need is right there to fax it and send it in so that you're not having to pull the chart and pull all that information. And it's a good way to follow up to make sure it gets done and gets back to you.
Good thought. Okay, any other thoughts on that?
And Matt Yelton has a comment.
Yes, Matt.
Just as a quick reference to the BLS 12 lead stuff before we get too far behind. We've got EMTs interested in Constableville just because it makes a big difference on what direction we transport in, whether it's north 25 minutes or south 30, 35 minutes to a PCI capable hospital. As you can imagine, I mean, it makes a huge difference for us. So a lot of support for that down here.
Good, absolutely. And you guys are kind of in a position like South Jeff is. You could go, either way. Where up here, we're not in so much of a position. So absolutely. Thank you. Okay. Any other thoughts on that?
Yeah, it's Andy Cartier. I just had a quick question about it. Are we having the machine interpretation kind of dictate whether or not it gets sent, or are we asking the facilities to do the interpretation on these ECGs, or what's the communication plan or the interpretation plan for when BLS providers acquire these?
So when BLS providers acquire these, they will not read them. They will send them directly to the facility for interpretation. Yeah, they're not trained in reading them at all, and they shouldn't be looking at what the, and it's something that as the CICs educate, the machine interpretation isn't always correct. So
yeah.
Again, okay. One of the points, and I'm guessing that Debbie and Paul, who have done this education, South Jeff folks, kind of discussed that and made that a point throughout their education.
Okay, just curious.
Would I be incorrect with that, Debbie or Paul?
That is correct. The key was getting that picture, getting it to the ED while the crew was loading the patient, getting them in the ambulance, and then making that call to the ED, talking with the ED doc and the appropriate determination whether we were going north or south. And it's worked very well. We've had a couple patients that we've gone south with based on the results. And we've had quite a few that have come just to Samaritan, but it was good practice, and we require our providers to do it twice a year at a minimum, and we offer it more often. So agencies that are thinking about doing it, start saving your pads that are expiring, and that's what we used to do the training with, was expired pads to get. Then they had to practice putting it on patients, and they had to be able to do it accurately without getting any noise, the noise factor or anything like that. And we were working with them to make sure that they did it in a very timely manner and that they weren't spending an exorbitant amount of time on the scene trying to do that.
So thank you. Any other questions? And hopefully everybody had a chance to review the education and the test that was put out there, as well as the sample SOG. Do you guys want me to go through the sample SOG that I kind of put together? I'll do it real quick, just in case, because I'm hoping to approve this all as a package. But basically, it just talks about the purpose. And again, the very end of the purpose, it is not within the scope of practice for a BLS provider to interpret an ECG. Again, it talks about the education and credentialing, and at least annually, training will occur. Training documentation will be retained by the agency and the provider's training files. Quality control, it talks about that whole piece that we just talked about, and ensuring that the medical directors are involved with this, and storage, just so you're not damaging the unit, and safety. If whatever their 12 lead unit is, it needs to be securely mounted or in a cabinet, depending on what their unit is, because you can buy standalone 12 leads at a less than $5,000 price tag versus the full-blown monitors that the ALS units use. And again, the required equipment is a unit capable of 12 lead electrodes, razor. They can, put the number in there. Most all the agencies have the razors with their AEDs as is. The transmission process, again, here's a sample one, but it would depend on the hospital that they're going to. Information that is suggested, for their radio report is added in here. They should be requesting appropriate ALS intercept, but again, if they can't get it, then it is what it is. And then again, if they're taking a picture or whatever, they have to make sure that they delete the ECG. There's no patient identifiers on the ECG when it is sent. Many of the agencies, especially the ones that participated in the ALS project that we had for STEMI, they have the tablets that they can take, or they have a tablet that they do EPCR on, and it's actually recommended, if you have such a thing, that's even better than using the cell phone. But in testing it with Samaritan, it seemed like the physicians were able to see it, even if it was done on a cell phone, enough, especially for Samaritan, to be able to make a decision on patient destination. So I have that in the SOG. So if there's no other thoughts on that, I would entertain a motion for the approval of the 12 lead BLS package as sent to you with the corrections I made.
I make a motion to
moved.
approve the whole package.
Okay.
Seconded.
Okay, so Dr. Gray, you're approving the whole package. Who seconded that?
Dr. Snicer.
Dr. Snicer.
Okay. Any further discussion? Hearing none. I guess we'll have to go through here. So I don't know what I do. Here's my list. All right, Dr. Cartier.
Yes.
Dr. Coates.
Yep.
Dr. Delaney.
Approve.
Dr. Heiss.
Yes, I approve.
Okay. Dr. Maynard.
He commented, yes, approve whole package.
Okay. All right. Approved, motion forward. So I will work on getting that together and out to the agencies. Thank you. Sorry for bombarding you guys all with a ton of stuff. All right, I will cover the FAST-ED in my program agency report. Is there any other old business that I didn't catch? Okay,
And we should probably just bring up that Dr. Maynard has submitted all of the necessary paperwork to become the CMAC doc for our region. And in conversations with Valerie, he's scheduled to be voted on at the December meeting.
Oh, why can I not get this to the right screen?
And do you have in your report anything about advanced providers and intubation?
Yes.
Okay.
I have some miscellaneous discussions at the end of my report, so I just have to get the PowerPoint to open up on the right screen, or I have to switch my screens. All right. Let me put this over here and then maybe it'll open on the right one. All right, hold on a minute. I gotta switch my screen so that I'm sharing. This does not want to cooperate with me. And now I lost all of you guys. Okay, I'm gonna stop sharing my screen for a moment. Now I'm gonna share my screen again, and we're gonna share this one. Sorry, guys. Okay, can you guys see the PowerPoint now?
Yep.
All right, hopefully we'll be through this fairly quick. Okay, but it won't advance. All right, so our stack and our TAC, we've been pretty busy working with them. The trauma committee meeting was the 24th. On the next slide, I have some stuff that came out of that to share with everybody. The next meeting date for our TAC is December 18th. Our stack was canceled in September because Upstate, who kind of does the coordinating of it, was having their survey done. So I'm not 100% sure when the next meeting date is, but a lot of times they correspond with our TAC. But through email, we've been working on a regional public service announcement to highlight the importance of seeking stroke and making it truly regional. And I'm going to see if this will play. It may not. But we did some filming locally at Samaritan Medical Center with Guilfoyle. And of course, it's going to be on my other screen. So this is just 30 seconds. Can you guys see that?
Yes.
Okay.
From across the region, we work together to provide safe, immediate stroke care. When you need it most. A stroke is a brain emergency. If you suspect a stroke, act fast. Is your face drooping? A, can you lift both arms? S, is your speech slurred or jumbled? B, it's time to call 911. Don't stay. It causes a delay in your treatment. Call 911 immediately. You suspect a stroke. We're working together safely for you.
So that was a 30-second clip. There's also a 60-second clip. And now the hospitals within the Regional Stroke Advisory Committee catchment area are working together on getting some television time, again, to promote stroke care. So I just wanted to share that with you. The other thing on the stroke front that we're working with SUNY Upstate, Central New York EMS, and of course us, we received some funding to do a FAST ED education video, which will be followed up by a test and actually some money to give a stipend to the first 120 agencies who have at least 50% of their providers complete the training. Again, this is just in process. We've kind of signed the contract on the funding, but we haven't received the funding yet. We're kind of looking at this being something that's rolled out in January. But SUNY Upstate will be working with the same company that did the PSA to create the video. And then after that, we'll be working on the processes. FDR HPO has been very helpful. So we'll kind of have the submission of the rosters come to our offices where we can then be able to send out the stipend for the first 120 agencies. And again, this is open to all Central New York EMS agencies and North Country EMS agencies when it comes out. So that's a work in progress. So from the RTAC, I just shared this for trauma transfers. Just, I guess one of the things they said is that with their transfer center, you have to tell them directly that it is a trauma patient. Again, they just asked to make sure that the trauma patients transferred in from an outside hospital that meet their criteria may not be eligible for direct admit. They will be directed for transfer to their ED. So, if you already have a patient admitted and then you're sending them down, if they are a trauma, make sure that they're aware of that. On the next screen, it talks, if they have a diagnosis at a referring hospital of crush injury to the thorax and no other injuries are identified, they should go to the trauma surgeon, not the thoracic team. So, and then on the EMS side, again, they had a discussion on following the CDC trauma triage field criteria. And even if it's an interfacility transfer, the EMS, please let them know through fire control down there when they're coming into upstate, excuse me. So again, those are some things just to share from there. So as I said earlier, the agency renewals, the list of agencies that's there have recently renewed their certificates. We've been copied out on them and updated our database appropriately. That does include City of Watertown Fire Department as a BLSFR renewal. The medical director changes, and this is provisionally approved, so I would entertain a motion to approve Dr. Casey Churn as Fort Drum Ambulance Medical Director. They have filled out all the appropriate paperwork.
I'll make the motion.
Okay, that was
Dr. Cartier.
Oh, thank you. Sorry. Dr. Cartier makes the motion. Is there a second?
I second. It's Ryan.
All right, second by Dr. Coates. And I'll go through the list here. Dr. Delaney.
Sorry, I was having a problem with my mic. Approve.
Dr. Heiss.
Approved.
Dr. Gray.
It appears that Dr. Gray has disconnected.
Okay. Dr. Sneisser.
Approve.
Okay. Dr. Maynard? He'll text you, yes or no.
Yep, I'm
No.
getting it. Approve.
All right, so just for discussion and something that we may want to look at, she is not a emergency physician, and while we make that recommendation, we do not hold all our ambulances. We have never been, like I said, it's just a recommendation because of the lack of emergency physicians. We have not always had an emergency physician to oversee, and we have many agencies that have family physicians or surgeons or others. So the one requirement when we looked at this through the state is, again, that they have a valid narcotic license, because this is an ALS ambulance. And in this case, she did. So we did make a recommendation that they consider looking for an emergency trained physician when I wrote the provisional approval letter. And, you know, that is something, I think the one thing with Fort Drum, you know, and I hope to be able to have an opportunity to talk with them at some point, is there's a lot of paperwork that goes along with changing a medical director. So I would like to, at some point, get a meeting with them and potentially discuss that maybe they have two medical directors, one being from the local area that's here to stay, with one and would be the primary signator if there's somebody who's comfortable in doing that, and then working directly with somebody there, probably under Guthrie, I would guess, being like an assistant medical director. I'm not sure whether they would be open to that or not, but that is a discussion I would like to have with them at some point. Level of care changes, there's been no new request. Mark Devers completed the AEMT inspection for me on Lisbon Volunteer Fire Corporation, so that completed their previous upgrade that was approved. No public access defibrillation. And we had no new regional BLS adjuncts, although historically with Turin Fire Department, they did a transfer of operating authority to become Turin Ambulance Incorporated. Historically, we've moved their adjuncts with them. I just want to ensure that we have a motion on the floor. I did approve these already based on history, so just to make sure that everybody's in agreement with that. I'm going to entertain a motion to approve those. Anybody make a motion?
So moved, Dr. Snyder.
Dr. Heiss, I second.
Okay, thank you. Dr. Cartier?
Yes.
Dr. Coates?
It sounds good.
Dr. Delaney?
Approve.
Maya, come back on.
No,
Okay. Dr. Maynard?
he's an approve.
Okay. And Dr. Schneider made the motion. Did I get everybody? Okay. Thank you. So EPCR, again, we're moving forward. Morristown went live with their EPCR this month. Turin is now working on getting hooked up with IPCR. And as you can see, we only have a few remaining paper transport agencies. And apparently my changes didn't save, because I did add in on that slide. Next week, Jonathan and I will be doing a training. The state is going to have a paper PCR portal now. So the remaining paper transport agencies, or ALSFR as West Potsdam is, that still has to submit PCRs, will be submitting their PCRs directly to the state. They will no longer be sending them to our office. So these other folks that are not listed here, like Hammond, Cranberry Lake, and Seaway Valley and Turin, may have to utilize this portal until they're up and running, unless we get them up and running before the portal goes live. But it looks like it will be in the very, very, very near future that goes live.
I believe Turin's going to be live within the week.
All right, make sure that they're coordinating with Jonathan.
I will, yeah. Jen and I were just talking probably 2 hours ago about it. They're anticipating probably within the week and a half ahead of us. So I'll make sure they touch base with you guys.
Yes, because
I talked to Jen about it already today.
Okay. All right.
And the PCR training for us is on Wednesday.
This week? I tried to do it next week. So we're doing it this week. All right. Oh, whoops, I did. I actually put in a whole new slide. Forgot what I did. So I actually had it right on that one, Jonathan. All right. So CME skills sessions. So because of COVID, we waived skills for the first semester. Now there is an education policy statement up there, and you can work in small groups. ALS providers should complete their second semester skills, and the expectation will be half of their annual didactic requirement. So I should word that, half of their annual didactic requirement. And the BLS skills are still due at the end of the year. There was some concern over opening up the skills session. So what we're asking is that agencies are still expected to submit scheduled sessions as usual. But posting to a regional calendar will be at the agency's discretion if they want others to come in. Regionally, we'll be working to set up skills sessions for providers, and some of the best practice is to, schedule a day where there's appointments, so you only have a couple of people coming in at a time to limit group size, and to be able to clean the equipment afterwards. And again, the reason that we're going to do regional sessions, so just an FYI for those in the other counties, we may be reaching out to you to help us with this, is for those agencies that are not approved CME agencies and may not have the equipment. So I may be reaching out to some folks to set up some stuff in their respective counties. And Mark Devers and I will work on St. Lawrence County. So EM resource, again, we're still working on it. Jefferson County, we're working with their emergency management at looking at their diversion policy and how they're notified. So that'll be moving forward soon. One of the things that Jonathan had figured out is that agencies don't necessarily have to get everybody set up in another system if they are utilizing third-party vendor, like I Am Responding or Active 911 or the Bricks 911, that if we have that email, it can be routed through that, and then notifications can be set up. So that's actually a huge time saver for departments. And the other thing that was brought up is that if a provider leaves or joins, they only have to be put into one spot. So, or leaves, they only have to be taken out of one spot versus agency leaders having to think about multiple programs that they have access to. So we'll be sending out some information regarding that. Our hope is to work with Jefferson County Emergency Management and, kind of figure out a timeline when this is how, and along with the hospitals, this is when we're just going to start utilizing this instead of the hospitals having to call and fax multiple people. So The opioid prevention program, again, we've been working with public health departments in the Tri-County area with their OD-MAP initiatives. We've been providing them reports as requested, and we're sending regular reports to St. Lawrence County. I am now on a quarterly meeting with the folks with public health and their OD-MAP people for St. Lawrence County. And I know Chris and Paul do a lot in Jefferson, and Bob does a lot of it in Lewis County. So as they need stuff there, they give us a call. So these are just a few miscellaneous things to discuss. And the first is AEMT changes. So while I'm working on a letter to go to the CMAC, the basics is, and we had discussed this quite some time ago, or excuse me, let me rephrase that. I'm working on a letter to go to the SEMSCO. They did an overall approval for a change to take place with AEMT to go to the national curriculum. Well, what happened is at the national level, the scope of practice was changed, but the curriculum hasn't been updated. So the motion itself was to move to the national curriculum in September of this year, but without that updated curriculum, there's confusion surrounding exactly what AEMTs can do and can't do. So when you look closely at the curriculum itself, it allows AEMTs, or it does not allow AEMTs to provide epinephrine 1 in 10,000 in cardiac arrest, IV push, but New York State had allowed it. But that kind of got missed in the translation. It also, and we knew this was coming, the intubation, but the epi we weren't sure about. So we've been reaching out, and especially with Debbie looking to teach an AEMT class coming up the first of the year and trying to get answers as regionally, what do we do with our currently approved AEMTs? What does this change for them? And the information from the state is keep everything as is. They don't have the stuff in place yet to make any changes. So basically my letter to the SEMSCO is going to be a recommendation that they don't put a hard date on changes because it causes confusion. It causes confusion with our educational folks and as well as here as a region on what our providers should be doing and shouldn't, because secondly, it's all still in the protocols. So, and there was no discussion on this at the last meeting, state EMS meeting. So Paul or Debbie, do you have anything to add to that?
I don't believe Paul is on. He is teaching paramedic Herkimer kids the labs tonight, so he had to get off early to get that going. No, our concern was, were we teaching it? Are we not teaching it? What is happening with our advanced providers right now? So when I put the curriculum together for this class, we show it in there. And Chris, has that been approved?
What's that?
The advanced class?
Yes.
The advanced class, the state has approved it as it was submitted. So I guess we'll work with Dr. Maynard because he's our medical director. I certainly don't want these students to spend a lot of time in the OR practicing intubations if it's not even going to be present by the time they finish the class. So hopefully we can get some guidance and direction on that before we go too far down that path.
Yeah, and it's just all up in the air. So other things that we're looking at that have an effect on our ambulances are, I'm hearing from many of them that there are challenges with the purchasing of medications due to the Drug Security Act, which is making many pre-hospital medications be sold as units and you take a small ambulance agency, and I'll use adrenaline for example as one of the medications where you cannot always just purchase, a couple. You have to purchase, at around $30 a piece. Instead, you have to purchase a whole, I don't know whether they come 10 or 25, I don't remember, but the price tag was like $700. We've really been pushing. Some agencies are able to work with the hospitals and get that, but not all hospitals do that. So we've been really looking at other ways to try and get those medications a little more cost effective because, one ambulance can't buy 10 of them and then share with the local because they're not distributors, share with other agencies. So that's been a challenge. I did put together a nice email and sent it to the state so that they were aware of this. The Drug Security Act is federal. So as we move forward, we'll look at maybe getting an exemption for ambulance. I don't know, but that is on the federal side. So I'll have to go to the appropriate contacts. I already brought up a little. Go ahead.
And it's Andy Carter. I'm sorry to interrupt.
No, go ahead.
Yeah, so this is one of the most frustrating things that I have noticed about New York EMS. Everywhere else that I've worked, Maryland, New Hampshire, Maine, etc., we've always gotten our medications from the hospital. Always, always, always. I feel like is that something that we can work on as a region? Is to have our medical. One of the things that I don't understand well about New York is that there doesn't seem like there's a medical resource hospital. There's a program agency in its place, is what it seems like. Is there any way as a region that we can not force, but strongly encourage hospitals that are acting as receiving facilities for EMS agencies to provide medication, even at cost, not for free, but even provide at cost? Would there be any benefit to having some regional pressure on that, on the hospitals in our area?
Well, so one of the hospitals in St. Lawrence County that doesn't do it, I have been working on trying to get a meeting with them. But I'm not even sure if even they must be able to, if the pharmacies can split them up, if they're going to get them to EMS. So that's something I have to learn before I could answer that. But basically the agencies tend to work with the hospitals. But with all these drug shortages, it's been crazy, but absolutely.
Yeah, this feels like something that needs a more, I mean, when we're talking about, Belleville or something like that is, or one of these places that has one truck and like two guys sort of deal, like they're not going to have that much push or pull with any of the hospitals. Like, hey, we need help getting medications. Like, I really feel like this would be a good regional thing for us to do as a council, to start working with hospitals to make sure that our services can actually have access to medications and still like be able to afford to put gas in the truck. You know what I'm saying?
I would use all the support I can get. I know I would have to reach out to local agencies and see. And again, while they may do it with one agency, that might not be the case with other agencies. So it's definitely something to look at, and I would appreciate all and any support that I can get on that. So course sponsor, I already talked a little bit about that. Currently, right now, the state is not approving new course sponsors. We have seen in St. Lawrence County, Clarkson University is interested in becoming a course sponsor, but there's a lot of paperwork to be done. Plus, they have a new dean of the Health Science Center coming in. So in the meantime, we've been working with Jefferson County EMS, and they will ensure that they're currently hosting a class right now at a Governor, which I do believe between BLS students and ALS students There's like 40 of them. REMAC, not ALS, sorry. BLS, original students and refresher students, there's like 80 of them. 40 of them. Holy cow. Sorry. I'm looking at my Part 800 changes. And at the December meeting, they are going to, again, go through the Part 800 changes. We'd sent it out to our agencies before. We have that just about ready to go back out to our agencies to get more feedback. As they have some stuff in there that would actually be a cost to the agencies. So for any of my agencies that are on here, watch for that email to come back out and take some time and really look at it good and give us some, additional feedback. We did receive some and we appreciate that. There's just some miscellaneous stuff. We still do not have an approved contract with the state, but we're going through Grants Gateway and I am sitting at STS determination level, so we're almost there. Our payments are lagging behind. FDR-HPO remains supportive of us. I am excited to announce that we got a PO for our fourth quarter ending June 30th, which means we should receive payment for that. It may only be 80%, but that's okay. Within 30 days. That just came today, so that's some of the stuff we've been doing. Any questions for the program agency? All right. Moving on to new business, preparedness. One of the things I just wanted to mention that was discussed at the last CMAC SEMSCO meeting was that it may behoove us as a region to work on protocols or preparedness if we're faced with, a second wave of the pandemic or actually any other crisis. So I'm going to send an email out and look to see about folks that would like to be involved in a committee on working on some regional protocols, et cetera, that we can kind of share and have more of an idea of where we're going with things before we get into a crisis. I already discussed the Part 800 equipment recommendations. Mark, do you want to add any more to that?
Ann?
Yes.
Hey, this is Chris. Part of your planning, not only for COVID or pandemic or whatever, do we have like civil unrest on the radar?
That's just what we need to work on.
Yeah, Mark and I talked about this. When some of this stuff started a while ago, we were in communication, our office, we were talking with AMR, we were talking with Oswego and Onondaga counties with their 911 centers, and they were helping us track really what was going on for the few days that things in Syracuse were pretty bad. And we did share that with some of our agencies up here, especially the ones that do transports, that's just something that you got to have on your radar. If the hospital needs somebody transported, you're going down to an inner city, and if those type of events are going on, we certainly need that situational awareness so that we can decide what's best for the patient and decide whether you want to really take that trip.
Absolutely. And I think that the reason I threw that on there was just basically out of the last state, when the pandemic hit, everybody was struggling to get procedures and policies and all of this, all the meetings and emails we all had over treatment of these COVID patients, that maybe we try and get some stuff in place for, civil unrest, respiratory emergencies, kind of, all of that ahead of time that could be approved and be just kind of there on the back burner. So, any of that stuff's got to be approved by the state. So I think it was just more so looking for a committee to think about all of the things that possibly, we could be facing and try to be ahead of the game. Mark, did you have anything on the Part 800?
Mark stepped away from the computer for a couple minutes. He is teaching my class a lecture real quick. He wanted me to mention that there's been some discussion about removing the 8.5 and 9.0 ET tubes from mandatory because they're not used as frequently.
Okay. Okay, that is more on the regional equipment list. What is the doctor's thoughts on removing those as required equipment?
I think that's a great idea. I've thrown away many of those in my career.
Any other thoughts on that? Is that a motion that you're making?
I would be happy to make that motion.
So Dr. Cartier has a motion to remove the 8.5 and 9.0 ET tubes from the regional minimum required equipment list. Is there a second to that motion?
I'll second.
Okay, Sarah? All in favor? Let's see. Dr. Coates,
Agree.
Dr. Heiss,
Yes, agree.
Maya Beck,
No.
Dr. Maynard,
Yes.
and Dr. Snicer.
Agreed.
Okay. So done. So the next part of the discussion was Mark's. So Melissa, did he leave you any on the interfacility transport?
I can pop in and see if I can, at a point where I can take over. Hold on one second.
All right. So while she's doing that, is there any other new business?
Karen just shot me a message. You can go ahead now, Karen, if you'd like.
Okay.
Mark said he'll be right there.
All right. Karen?
I misread Karen's message. Never mind.
Oh, okay. All right. Any other new business?
Anne, did you want me to just briefly share with people the proposed agenda for next year, and that we're just gonna, take it to the REMSCO tonight for approval?
Yep. That was next on my list. I actually you can go ahead. I'll send it out once it's approved, because I actually think one of those days on there is a Tuesday, but didn't get a chance to check it.
Oh, okay, let me.
Here,
So, we were looking at the first Monday in February. The April one is our annual meeting for the REMSCO, so that was April 5th. Then we have the spring fling dates down there. We do have the conference center reserved for that, and Janine is in hopes that we all can get back up there. She misses everybody and would like to see the group back there. Then Monday, June 15th, and Monday, October 18th. And I would like to say that we may move these a little bit if we're meeting on, say, Monday the 1st, and they're going to have state council the following week. We may move it so that we line up so that we can make sure that we share with everybody the information from state council to keep everybody most informed on what's going on there.
It'll be Monday, June 14th, Debbie.
June 14th, Monday, June 14th, okay?
Yep.
Thank you.
Yep, no problem.
So if this is approved at the REMSCO, then
I can't see what month you're in.
I will make sure that
See the month.
I get it sent out to everybody. Okay. Mark Devers, are you back?
Mark has requested to table that for this meeting.
Okay. And I apologize to everybody for being so long. We just had a lot of stuff going on and stuff to go over. I feel like I've talked all your ears off. Is there any other new business? Hearing none, I would entertain a motion to adjourn. No motions to adjourn out there?
So moved.
All right. Thank you, everyone. And I will talk to you again soon. Bye.
Dr. Delaney?
I
And
think she hopped off, but I did tell her, Dr. Snicer, that you needed to talk to her.